All right, good morning, everyone. We're going to go ahead and get started so we can try and stay on schedule for today. Our first speaker this morning, I actually met her at a conference in San Diego about a year ago, I think. And we were sitting having lunch, you know, I didn't know who she was. We just introduced ourselves. And then she told me she was a genetic counselor in Indianapolis. And she said, "Oh, can I come to your conference?" I'm like, "Oh, you can do a little more than come to our conference." But Laura Oehlman is a certified genetic counselor with a Master's of Science in Genetic Counseling from the University of Cincinnati College of Medicine and a medical degree from Indiana University School of Medicine. She's an inpatient genetic counselor and cares for patients who are admitted at Riley Children's University Hospital or Methodist Hospital. Her role often includes coordinated testing for newborns in the NICU, sharing and explaining new genetic diagnoses, and empowering families with information on rare and ultra-rare conditions. So let's welcome Laura.
All right. Good morning, everyone. Thank you so much for having me. I am so honored to be here and be welcomed into your community this morning. So like Lindsay mentioned, I am here in Indianapolis, and I will be sharing a little bit about genetic counseling for 11q disorders. All right, so I will start with a little bit about myself. I love talking about myself, and so now you all get to know a little bit about me. So this is my dog. His name is Tonka. I think he's the cutest. And if you get nothing out of my talk except that I have a really cute dog, I will have done my job this morning. So that's him. I also love seeing pictures of other people's dogs. So if you want to come up to me and share your animals, please come find me. I will love that. All right. Second, I recently got married. I got married at the State House here in Indianapolis. It was a really small, just legal ceremony. I think we're doing a bigger, more traditional thing in the Dominican Republic later this year. I really highly recommend checking out the State House. It is just a block or two over. It is free and open to the public, and it is a stunning building. This is the rotunda, which has beautiful stained glass. And so I am now a wife, which is a huge responsibility that I don't think I was quite prepared for, but that's really cool. And then I also play ultimate frisbee. I also don't know how this is a sport. I don't know who came up with this idea, but it is throwing a frisbee around and sprinting and playing football, essentially with a disc. And I am obsessed with this sport. It's how I met my husband. And I think it's really, really cool. So, you know, I wanted to share this because, you know, first and foremost, like I said, I love talking about myself, but a lot of the things that make me who I am don't have anything to do with my medical, you know, journey or anything like that. And so a big part of my talk is going to be about, you know, medical things. And I'm sure that you've all had experiences where you go into a doctor's appointment or you see a genetic counselor and they spend a lot of time talking about the medical side of a genetic diagnosis. But I think that sometimes we lose the side of things. And I do really want to encourage you all to, you know, share that with your medical care team. Bring your poster to your appointment. I would love to see these. Like if someone walked in with a poster about their child, it would make my day. So those are really, really cool. And it's really fun to see, you know, the things that make our families unique and things that are outside of the medical realm. So next, I will talk a little bit about what is a genetic counselor. So I don't know how many people have met with a genetic counselor or even know what we do. I think I could do an entire talk on what a genetic counselor is, but these are the things that I thought would be important to highlight and things that I kind of found is the most reported parts of being a genetic counselor. So one of the roles is to evaluate personal and family medical history to assess the risk for inherited conditions. So there's a pedigree there. I take lots of pedigrees as part of my job and talk about a lot of family members and what conditions and symptoms that they have experienced. Part of my job is also to translate complex DNA information into actionable steps, guiding people through genetic testing options and providing emotional support. And so I think the part of my job that I love the most, I would say, is trying to synthesize lots of really complex medical information into a really organized and patient-friendly, digestible. So next, I will kind of go through what genetic counseling looks like for a new diagnosis. My role at Riley Children's Hospital and the Indiana University Hospitals is an inpatient counselor, so I only see individuals who are in the hospital. A lot of my patients are newborns who are in our NICUs here at Indianapolis, and a lot of them are getting genetic testing really, really early on. As part of my role, I frequently am giving a new diagnosis to family, and over time, that has evolved a lot. I've learned a lot from my patients. And last night, I actually got asked, before I met Lindsay, had I ever heard of Jacobson syndrome? And I hadn't. I remember being in that conference and she was presenting, and I'm furiously, Googling what it is, what gene is it, what each of the 20,000 genes is this, and then realizing that it's a lot of them, and it's a deletion, and it's more of a chromosomal rearrangement. So I remember kind of learning about that, and so I want to be fully transparent that I am not an expert on this condition. I kind of approach this presentation the same way that I approach any new diagnosis, any ultra rare condition that I probably have never heard of. And that's to really rely on my colleagues. I reached out to a lot of them and I was like, hey, what do you know about this condition? And then I dug into the literature, looked into some of the reports that we had available in our database, and so I put together as an example of a counseling session. Let me know if you have any thoughts. All right. So first and foremost, I start off by talking about kind of a background of genetics. So where is DNA found? How does this even work? So in all of our body, we have millions and millions of cells. Each cell has chromosomes, which are these neatly packaged pieces of DNA, and they are really well organized. So I kind of think about it, like those library, like those big bookshelves that move around so you can go exactly to the part that you need. And so I usually describe it as, when your body is forming your arm, only a little piece of that DNA needs to be utilized. And so the rest is packaged really tightly and kind of kept separately and not touched. And so there's lots of regions within that need to be accessed at specific times. But for the most part, it's kept nice and tight and really well protected. And then when we start unwinding it and looking at that spelling of that DNA, it's very specific. It's made up of 4 different letters, and how that information is spelled is really important. And that leads to a protein product, or what actually builds our cells and helps our body function. So there are different types of genetic testing. I feel like usually when people hear genetic testing, they kind of have an idea of maybe what they've had done or what they are most comfortable with. So I kind of wanted to go through the different types of genetic testing that is currently available. So we can have non-invasive prenatal screening or testing. This is a test that is done on maternal blood during pregnancy. And so there is kind of this cell-free DNA, meaning that it's just not in cells, it's just free-floating DNA that's coming off of the placenta. It's in mom's blood. You can see it here, it's mixing with mom's DNA, and we can get a sample of that blood and look at baby's DNA or placental DNA and maternal DNA. And the lab has very fancy ways of separating out baby's DNA from the pregnant person, kind of looking at regions that differ, and so they can separate out baby's DNA and the pregnant person's DNA. So this can detect extra or missing chromosomes or pieces of chromosomes in that cell-free DNA. This is a screening tool because theoretically the placenta and baby would have the same DNA, but that's not always the case. Sometimes it can just be in the placenta, and sometimes it can just be in baby. And then another type of testing that we have available are karyotypes. And so I kind of describe this as if you look at a cell, you open it up under a microscope and you're just looking at the amount of DNA. This is what it looks like. So these are all of our chromosomes. They're in pairs. We usually get one pair from mom, one copy from mom, one copy from dad. And then there are 22 chromosomes that are coding DNA. And then the very last set are our sex chromosomes. So females typically have 2 X chromosomes and males typically have 1 X and 1 Y. And karyotypes can also detect large rearrangements or large pieces, but it has to be big enough that they can see it on this image. And so I can't see that. I rely very heavily on people in the lab to tell me if they can see any extra missing pieces on this kind of imaging, because it's really hard to see and takes a lot of skill and a lot of training to be able to detect that. Another type of methodology that we have available is a chromosomal microarray. And so this is frequently referred to as a CMA, and actually looks at the dosage of the DNA. So how much is there? If there are any differences, usually it's like a straight line down, meaning that you have 2 copies of everything. If there is a deleted region or an extra region, it will kind of flag it as a different dose of that DNA. And so this can look at much smaller deletions and duplications. But the very first step of this testing methodology is chopping it all up. You chop up all the DNA and just see how much is there. And so you immediately lose any kind of structural information, any kind of rearrangements, or things that are balanced, meaning that all the right information is there, but it may just not be in the right place. And I'll speak a little bit about that later. But this also doesn't allow us to sequence any of the DNA, looking through the spelling of that information. All right, and then the test that I order most, because I do see 2-day-olds who may have pretty non-specific symptoms, is genome sequencing. It's a very comprehensive test. It sequences all of the DNA, all 20,000 genes that we currently know about right now, sorry. And then that information is kind of filtered and sorted through the lens of what someone is experiencing. So in this example, for patient Q, we sent genome sequencing analysis. It looks at all of the genes, all the information that is needed to make protein, and then the information between those regions. Then knowing Q's symptoms, which are pretty non-specific in this case, of unique facial features, kind of feeding difficulties, a ventricular septal defect or a heart defect, and a concern for immunodeficiency, the lab was able to detect a positive change. And so when I'm introducing this test, I do talk through the different types of results that we can get, including uncertain results where we find just normal variation that could be significant. All right. And so for Q, we sent I changed my testing methodology. We actually sent a CMA for Q, and this is what we found. So he has a deletion in 11Q from 23.3 to Q25. And so that, if you look at the chromosome, just tells you the bands that are deleted. And the actual letters in that deletion is kind of a 119 million to 134 million deletion, which is about 15 million letters. So thinking through kind of that first image I shared with you, we are missing, about 15 million of those ATGC letters. And then for Q, this is considered clinically significant and would be consistent with a diagnosis of Jacobson syndrome. So, as I talked about, with this deletion, there's lots and lots of genes in it, and it can depend on the size of the deletion. And the resource that I love most is called Franklin Genetics. It's really pretty, and in my job, anything that is, I think is really helpful. So I looked at the number of genes in this region. So there's a total of 121 coding regions, meaning that that's the information that makes the proteins, the part that's being read in our body. And then within that, there were 33 regions that are haploinsufficient, which means that having only one of those genes is thought to, be related to some symptoms. And so it is a lot of genetic information that is within that region that is missing for this patient. So then I go through the features of Jacobson syndrome. I have included them here. I don't want to spend a lot of time going through them because I'm sure that you guys are quite informed about that. But the things that I highlight most for families is that it's an extremely variable condition, that knowing the size of the deletion or where it's at is not going to help us predict what features someone may experience. And I also share, that this is a long list of things that have been reported in this condition, but it by no means is comprehensive, and that every child is not going to have everything that is highlighted in this list. And so it just provides some information of the things that can be seen, but that ultimately their child and their child's needs are going to be what we manage and what is our long-term care for them. Okay. And like we've highlighted a few times, this is an extremely rare condition. It's present in about 1 in 100,000 individuals. And so to be in a room with so many people who have this condition and who have experienced it has been just an incredible experience. And I've already learned so much from all of you, and I appreciate you welcoming me here this morning. All right. And then the other, I also wanted to highlight, so I do frequently talk about unique facial features that can be present, but I also love to highlight that most kids look like their parents, right? So like, even though there are some unique features, though that, there are really subtle things, and none of these things in and of themselves cause, medical concerns or things that families may even recognize in their children. And that from a genetics lens, we are trained to find really, really specific things, but that most of these are not features that would be kind of, overly apparent. So that is how I usually talk about that. If anyone has other thoughts, please let me know. But I also wanted to highlight a couple of years ago when I went to a conference, there was a photographer there, so sorry, who works with positive exposure. I don't know if any of you have heard of this group, but he was a professional photographer and had been working in fashion for a really long time and was kind of being told what is being used. So he started working with a lot of advocacy groups and individuals with unique features, and has highlighted a lot of their conditions. And so he is super cool. He's a really cool person, and their website is amazing. So highly recommend checking that out if you haven't heard of them. All right. And then some other health conditions that I share with families. And so those are highlighted here. And so then, a lot of times when I'm getting this as a brand new diagnosis, families ask, okay, well, what's the next step? What do we have to be concerned about? What are the things that we want to make sure to get checked out? And so usually that starts with a baseline cardiac evaluation, looking at the heart, how it is formed, and then looking at some lab levels. We also recommend looking at ophthalmology and getting your eyes checked, as well as kidneys and hearing. And then I share some typical management. A lot of people may be involved in your child's care. It really depends on what they're experiencing. And then a big part of my conversation is that recurrence. And so the majority of times Jacobson syndrome is de novo, meaning it just happens brand new in someone. And so parents may have chromosomes that are typical, and then when that child is developing, they have that deletion. It can also be a translocation. So in about 15% of families, a parent may have that. So that means that one section of one chromosome is changed from a different section of the chromosome. And so parents would typically not have any symptoms because they have all the right amount of information, but it's just in a different place. And this can lead to then having a child with an unbalanced translocation, where there is a loss of one part of a chromosome and a gain of a different one. So as highlighted here, for this little part in green, there are going to be 3 copies of that small part. And then for the red chromosomes, you have one that has all the information, and then the second one has a small deletion. So there's a small part of this red chromosome that is deleted. It has been replaced with a piece from the green chromosome. So there's a duplication and a deletion in the child. And so, it's really, really hard to talk to families when this is the case, because the recurrence risk calculation is really specific to where that deletion and duplication is, where that translocation occurs. And it is a risk factor for pregnancy loss or recurrent miscarriages as well. And so those numbers can be really hard to calculate. But the mechanism or the way that translocations are inherited is that, one parent has typical chromosomes, one parent has a balanced translocation, meaning that here we're using orange and blue. This little piece of orange is on a blue chromosome, and this little piece of blue is on an orange chromosome. I think I said that wrong. But when you are dividing that information into the gametes or the cells that are going to be passed on to your children, they can either receive the copy of each chromosome that doesn't have the translocation. And so that would be, typical chromosomes. You can inherit the copy that has a little bit of orange and a little bit piece of blue. So that would be a balanced translocation. So we would not expect that child to have any features, but they could have children with an unbalanced translocation. And then you can also have the blue chromosome without the translocated region and the orange chromosome with that little piece of the blue chromosome. And so that would lead to a deletion of part of the orange and extra piece of blue. And the same with the other, part of that. So then when these gametes are mixing with the other parents, that would lead to either a child who has typical chromosomes, a child who's a balanced carrier, or a child who has a duplication and a deletion. Okay. And if you have any questions, my contact information is at the beginning of this. You've now all received genetic counseling from me, and so you are welcome to call me with questions if you want me to walk you through these calculations or walk you through the genes in a certain deletion or a certain region. So happy to do that, and I love hearing from families. So please reach out. All right. And so then I did pick the easier of these to talk about for recurrence risk. So in this situation, Q's deletion was not inherited from a parent. We did parental studies and found that they do not have a translocation. So the risk for siblings, when it's de novo, we say that there's a less than 1% chance. And so in genetics, I'm sure you guys know, we never say never. We never say 0% or 100%. It's always somewhere in the middle. And I love that I just get to live in the gray zone. But there are instances where, other egg cells or other sperm cells could have the same deletion. And so it could be that parents' overall cells have typical chromosomes, but there are other affected gametes. And so we never say never. And then for any future children, I do talk about this even when, baby is like a week old, and I'm like, I know this is not your priority. I know that you're not thinking about the grandchildren that you're gonna have someday. But I do always talk about the fact that once that deletion has been detected in an individual, there would be a 50% chance of them passing on the copy of chromosome 11 with the deletion, or the copy of chromosome 11 that does not have that deletion. All right. And then I love sharing resources with family. Usually there's not a very specific or dedicated one. And so I love that you guys have a wonderful resource group and have such a wonderful community. And there are sometimes when I will share symptom specific groups, if someone has a congenital heart difference, sometimes connecting with other families who have a similar heart difference in their child. Still be really helpful, even if there's not a support group for their ultra rare condition. But it is always wonderful when families can connect with someone who is in their community and who may have a similar diagnosis and may be experiencing similar life, challenges and celebrations. So these would be things that I would share. So the 11QUSA.org resource group, you guys, there is a unique website that has packets on different chromosomal differences. So having extra chromosomes, having missing chromosomes or monosomies, any deletions, duplications that are on the more common end of our spectrum. They have a specific packet of information. I like these a lot because even though they are pages and pages of information, they are often written and include individuals who have that condition. And so getting that patient perspective, I'm sure you all are aware, can be one of the most helpful things. And so that is usually the last thing that I talk about. And overall, part of my job is also supporting families with a new diagnosis. And I think that is really different for everyone. Sometimes when patients are discharged, I follow up with a phone call and I call them with the result. And I always ask, hey, I have results back. Is now an okay time to talk? And I've never got a no. And I'm sure that there are some families who have not been in a place where they can hear that information. And so that's another one. If you have other ways that I can ask that, please let me know. But when I call someone with the result, I usually kind of just provide a brief information about that condition, set up an appointment to talk through them, put together information for them. And, it's always hard to kind of gauge where families are at and how much information that they're ready for. And sometimes that really depends. It's a newborn who just went home for the first time. They may not be ready to hear that, and they're just enjoying being home and out of the hospital. And then there's other times when it's a family with a older child, a teenager, and they've been looking for a diagnosis for a really long time. And that feels really different. And so I just try to ask families, what does this mean to you? I don't try to assign emotions to that diagnosis. I kind of want to hear from them what that is like. And I also know that probably most of you have things that you remember about when you received that diagnosis. I've had families tell me, you were the one in the red dress with a really, really good, really pretty smile who told me that, this was what this condition was, and I had a lot of education, and I think that's really nice to hear. So I love what I do. I love my job, and I have a lot of privilege to share information with families and meet them through lots of different medical challenges. So that is all I was planning on sharing. But if you guys have questions, I would love to answer them.
Does anyone have any questions offering?
Maybe you should be asking this question. Thank you. First of all, thank you for giving the groundwork for my talk tomorrow, so I don't have to go over all this. Thank you. I think it was about a year ago or so, Lindsay shared with me a very staggering statistic that I wasn't aware of. Basically, there are not enough good people like you, genetic counselors. I think the statistic that Lindsay shared with me was something like 80% of families that get a genetic diagnosis, for whatever reasons, never actually end up getting to meet with people like you. And I guess my question for you is, how do you, other than trying to clone you, which I don't know if we have that technology yet, how do we overcome that gap between the information and the distribution of knowledge? I mean, ideally, I would love that every time a positive Jacobson syndrome test comes up, it gets put into some national database, and the family is automatically at least referred to our group or others, but I don't see that happening. But I'd like to hear your thoughts.
Yeah, that's an excellent question. Yeah, you are correct. Even in Indiana, I work at Riley Children's Hospital. I work with a lot of counselors at Indiana University. There's about somewhere between 40 and 50 of us here in Indianapolis. But I'd say that probably within the rest of the state, there's maybe 5 to 10 supporting everyone else. And so it's great if you have the resources to get to a metro area, maybe connect with a really large children's hospital. But overall, I think that the laboratories that are doing testing, so if you've heard of like GDX or Invitae, they are trying to have more genetic counselors within the lab who can help anyone who has testing through that lab. It's hard because for chromosomal conditions, those usually go to a cytogenetics lab, and those are usually more academic labs because they take really trained and highly skilled technicians to read and interpret those cytogenetics labs. And so I think it's really hard. I think that I would love everyone with a new diagnosis of anything to get genetic counseling. I get to focus on a lot more than just the medical needs of someone, and I get to, use the counseling part of my training to explore what family is going through, get to hear about things outside of the medical needs that someone may have. And so I don't know if that answers your question, but yes, I would love to have more genetic counselors throughout the US. And I would also love more clones of me because as you know, I love talking about myself, and I think other questions.
I have a question. I had my son after my daughter has Jacobson's. I had my son afterwards, but didn't have her diagnosis yet. And he came out typical, and we never were tested, me and my husband, because of that. We didn't think there was a reason, but now when you're talking about this, first of all, I didn't realize the balanced translocation was 15%. That's a little higher than I thought. And he could have, like if one of us had a balanced translocation, then he could. So what would you suggest, that the parents do testing now, or that like my son do testing?
That is a great question. And part of my job is kind of talking through what makes the most sense for your family. So if you and our husband or dad want to get testing, we would be happy to coordinate that. If that's information for kind of just your family in general. If your son is deciding on having children and he's the best person to test because he's the one, making those decisions, that would also be a completely appropriate route to take.
We're past those days. We don't.
But you might just be curious. You might just be like, hey, I want to know what my chromosomes look like. I do. I'm super curious. But yeah, it really is just dependent on what makes sense for you and for your family.
Okay.
Thank you. Great question.
Good morning, and thank you for being here. I think the information that you shared today is so insightful and necessary. 38 years ago, when we were going through the beginnings of all of this, it took 3 years before anybody looked around and to see why she was having so many complications. And it was even after the VSD repair, all kinds of stuff was still going on. They were telling me that it was just a hole in her heart, and all these complications were related to the hole in her heart. And we'll repair the wall, which apparently was much bigger than they thought, and everything would be fine. Only it was never fine. Her immunity was still bad. Her bleeding disorder was still bad. And nobody could understand, or I didn't understand why. So I think everything that you've learned and are passing on is so relevant now and necessary, because people who have new diagnoses now, I was handed the Jacobson paper, and that was all. And that was 3 years after we were already going through all of this, and they didn't have much information for me. So this group being established and you participating is huge and unappreciated. So thank you for that, because those new diagnoses have such a different path than we had way back in the day.
Thank you so much. And yes, so the genome technology that I shared, that is the test that I order most often for my patients, is something that has only really been clinically available for 3 to 5 years. We had exome sequencing before then, but that wasn't great at looking at copy number variants, so deletions and duplications in chromosomes, and often you had to order an exome and a CMA. And then if you're worried about any kind of chromosomal translocation, you also have to order karyotype for that structure. And so at this point now, we've ordered 3 different tests that I know are completely different. But sometimes when you explain that to family, they're like, why are you ordering so many tests? And the karyotype has to be done on blood because you have to grow the cells. And then families, in a 2-day-old don't want to give me that much blood. So that's totally fair. So yeah, so I think the diagnostic journey has changed a lot in the last 3 to 5 to 10 years. And we're trying to catch things early, like I showed with the cell-free DNA, that can be done during pregnancy. So that's extremely hard because historically, a lot of our testing and a lot of our diagnoses were in individuals who had more severe features, had more medical needs, who were seeing a lot of different specialists who could recognize a syndrome. But I think that over time, we've noticed that people can have conditions and have really mild to no symptoms, and they would never have had genetic testing or had this diagnostic kind of odyssey or intense testing strategy because they were on the more mild end of things. And so now that we're doing comprehensive testing as a first-line test, we're seeing that a lot of our genetic test conditions in general are much more of a spectrum than we initially thought.
First, I thank you for what you do. I'm lucky enough that even 22 years ago, when she was born, we were in Orlando, which has 2 great hospitals, children's hospitals. But the genetic part of it, we went through both spectrums. We had at the beginning when she was in utero, when we found out, not so good experience. But then after she was born, it was very vital in getting the early intervention. The genetic counselors really are tuned in with not necessarily the Jacobson. She was kind of like you, where at first she was like, you're going to teach me probably more about Jacobson than I know, but I can get you hooked up with the right people. And that was very vital. And so thank you. And for the younger people, how late, because I think our genetic counseling she went like a lot longer. I think she saw her until she was like 7 or 8, I think. But I think typically in Florida, it was typically until 5, until school age. Is that the way it is in Indiana? And is there like is there anything like nationwide that says we provide genetic counseling until this time?
No, so in Indiana, I don't know about other states, but we love to hold on to our patients. I see 2-day-olds, I see, 85-year-olds in the adult hospitals. I am happy to help coordinate testing for anyone. And so within our clinics as well, we follow adults, and they're always kind of our patients, and the support and the needs change a lot, as I'm sure you all are aware. Maybe the initial stage when you're trying to figure things out and trying to coordinate a lot of therapies, and I genuinely don't know how you guys all do that because that sounds exhausting. Trying to schedule all of that and also the organization that it takes to make sure that those don't overlap is amazing. But trying to get all of that started is really hard. But then once I feel like you're kind of in those things, there's a natural progression to what that looks like as kids get older. And so it may change, but we still follow our patients every 1 or 2 years until they want to stop seeing us. It's usually more patient-led at our. Yeah.
I had a question about, so when my 11Q child was in utero, I have severe uterine growth restriction. So they tested for, they just did a basic genetic test, and then they asked if we wanted microdeletions at testing. And we're at Boston Children's Hospital. So lots and lots of resources. So we did the
we did the whole thing. Everything came out completely clear. So throughout the whole pregnancy, we had no idea what was going on. And then they were diagnosed at, I think, 2 weeks. But so I keep saying to people, like, I'm sure Jacobson syndrome is now on the panel of microdeletions, but I actually have no idea. Is it now? Is it part of the standard?
Oh my gosh, that's a great question. So if you know anything about NIPT, you think they're all the same and they're really not. There are some that only look for Down syndrome, trisomy 13 and 18. Some have microdeletions included, so like DiGeorge syndrome 22q1 1.2. There's a couple other ones, and they also look for any sex chromosome differences. So Turner syndrome, or only one copy of the X chromosome, Klinefelter, XY, and Jacob syndrome, which is XYY. Those are included in kind of like that next tier. There is a genome-wide screening that will look for any deletion or duplications greater than, I think, 5 megabases. And so for those, you could pick this up, but it's not one of the ones that is included as a microdeletion for like that second tier. And not very many people offer it because at our institution, it's like a stepwise approach, which I have mixed feelings about doing multiple screening tests. I also forgot to mention that usually for NIPT, it is a screening test. It's that placental DNA. And so any kind of confirmatory or diagnostic testing would then have to either be done on an amniotic sample or a small piece of the placenta called a CDS, or you get a little part of the placenta and you do chromosome analysis on that. And those are the diagnostic tests that would then confirm or rule out that screening test. So, great question. And
So there's a lot more kids out there who have it. I kind of had assumed with science progressing that
Yeah.
we would know by now and know the number. My second question is, I remember they were diagnosed that we saw a geneticist very soon after, but I don't remember being offered a genetic counseling service. So, and I'm sorry if I missed that first piece, but what kind of information is different coming from a counselor versus geneticist? I felt like he was very nice and explained everything, but what would be the difference in the two?
Great question. I think a lot of our roles overlap, and there are lots of institutions that don't have kind of a one-to-one geneticist, genetic counselor support. I work at a very big institution, and so we do have a lot of bandwidth to meet with everyone with a new diagnosis, but I know that's not always the case. I think that most often the counseling piece comes into it, and so it's more just checking in. I get the pleasure of seeing them in a few days when they're still in the hospital, and so I can just check in and say, hey, I know there's a lot of new information. You've had a little bit of time to digest the majority of it. Like, what are the new questions that have come up? Or, hey, I know that yesterday we had a really big heart surgery, and I'm just coming in to see how you're doing. I don't have to talk about anything genetics related. It can just be getting to see you and support you and talk through kind of what your concerns are or what's going really well. I saw that, this other thing came up and we want to celebrate that too. So I think I just get a lot more freedom and bandwidth to support families and follow up with phone calls and be more of like a continuity piece than the geneticist can do. Great question.
Thank you so much for being here and for your talk. I did not see a genetic counselor at all for my daughter. And we saw the geneticist once, and then we received a letter in the mail and with your diagnosis, and that was it. And so I was really amazed to hear about Jeremy's having 7 years worth of genetic counseling. I was like, what? So I was pretty flabbergasted. That was great. They had that experience because it was we had Google. So so my question though is, excuse me. Yesterday when Paul was talking and he had a picture of a little chip that was like a genetic test, and it was like the size of a quarter, and you can probably correct. Yeah, so my daughter had the karyotype. Is there a reason that she at this point at 16 would it be beneficial for her to have that one that he just was saying, at this point, would there be a benefit for her to have that in addition to what she had that we know about from 16 years ago?
Excellent question. And again, kind of what makes sense for your family. I think the benefit is knowing those breakpoints can give us information about what are the genes that are included. But as I'm sure you guys are aware, the size of the deletion doesn't fully one-to-one correlate with the features that can be seen or the severity of each individual feature. And so kind of the biggest benefit would just be being able to detect the breakpoints. I don't know that at this point it would change any kind of management, but it would just be more like additional information for you and for her.
Thank you.
Yeah.
All right, there are still like 10 questions in here,
Come find me.
but
My phone
but
number-
Laura is staying with us all day today. And so maybe during lunchtime or something like that. I know there's 1,000 questions and we're so grateful for her to be here, but we need to start moving on to the